wake up a little bit, okay? All right, Kelly, would you like to come draw for me? Three, 8, 7, 6, 4, 5, 1. 3, 8, 7, 6, 4, 5, 1. Blue. Go ahead and draw another. 3, 8, 2, 9, 4, 1, 6. Red. 4, 1, 6. 8, 1, 4, 6, 4, 8, 4. Blue. 8, 1, 4, 6, 4, 3, 2. Blue. I'm getting close, aren't I? 3, 8, 2, 9, 4, 2, 7. Red. Anyone? Bueller. 2, 7, 3, 8, 1, 9, 1. Red. And we'll go again. 8, 1, 4, 6, 6, 4, 3. 4, 4, 3. 3, 8, 2, 9, 4, 9, 3. Okay, here's what's going to happen. All right, I need my Kyle and Morgan, if you will assist me with this, if you will stand up for just a moment, we're going to ask a couple questions. It's trivia. It's very easy. I can do it. You can do it. If you know, first person raise their hand. Who's today's first speaker? Who was the first hand raised, guys? Winner, winner, chicken dinner. Come get a t-shirt. Okay, guys. That is all we're going to do right now because everybody clearly needs more coffee. Yes. Today, your moderator in this room is Kelly Askew, this beautiful lady in front of me. We all know her and love her. If you need anything, please, by all means, feel free to reach out to one of us today. One of the questions this morning that has been asked is, do I have to sign in again? As long as you signed the paper yesterday, you are good, okay? If for some reason you did not sign the paper downstairs yesterday during registration, please make sure you do that. It's still in registration. Any questions with that, please let me know, okay? Have a great morning, and I'm gonna turn it over to Kelly. Is it time? Is Dr. Smith here? Paging Dr. Smith. Okay, new trivia game. You can't cheat. I got a question. If you know what time the conference ends today, raise your hand. Oh, I saw you first. Ah, winner, winner. It's true. It says through 1 o'clock. They're really soft. Come on, represent. Did everyone enjoy their breakfast this morning? Thank you. Yeah. Hey, everyone, I just got a text message. If you are needing credits for the AOL, DOL, those will be available after the first break. I know some of those adjusters are having to get back out of back to the airport. So if you're here to get state credits for the DOL, that sign-in form will be available after the first break, which is the 10:30 break, I think. Steve Garrett from the DOL is getting that taken care of. So it will be announced on where it's going to be, because I don't know, but I'll figure it out. Who wants to tell a scary adjuster story? Like the worst one you've ever had? Or nurse case manager? I heard something about a needle in the eyeball yesterday. A needle in the eyeball? Oh, I hear Dr. Smith is coming.
Paging Dr. Smith.
What?
Somebody found, the hotel found keys for a car.
Next announcement. The hotel has found keys for a dark blue Nissan Altima. Tag number 58A DC35. So does that is your vehicle? They're at check-in for the hotel. There he is. Do it.
Y'all weren't legal. All right. All right. Good morning. Dr. Todd Smith is going to be your first speaker today. Dr. Smith is a board certified orthopedic surgeon specializing in orthopedic spine surgery. He has over 10 years experience and his practice includes cervical spine, minimally invasive spine, and revision spine surgery. He has served on the advisory board for the National Tissue Bank and has been a faculty advisor to residents and has been a speaker and surgical instructor for spine surgery, including minimally invasive techniques. Welcome, Dr. Smith.
Is this on? It's on, right? Yeah, I was in the other room. It's like, thank God, this is a smaller room. I like the way that I said over 10 years. It didn't date me very much. Okay, so I wanted me to talk about structural safety and best outcomes. And really, it should be the other way around. It's best outcomes and structural safety is part of that. Well, I was winging it anyway, so I guess we'll just. There we go. So there's a lot of things that go into achieving our best outcomes, and these are just some of them. There's creative approaches that we have, navigation, neuromonitoring, improving our biologics, newly engineered devices that we have. So we're going to talk about creative approaches. There's a lot of non-traditional ways. Hang on. Let me just check them real quick. There you go. Missed one. So before we start, just talking about traditional spine fusions. And this has a long history. Really started off primarily with posterior approaches. And in the traditional posterior approach, we're making big incisions, taking the muscle and stripping it off bone to get in and put in bone graft and rods and screws. It's a very good procedure for the right problem, and we still use it. But there is a lot more surgically induced trauma to the soft tissue envelope in doing this. And because of that, compared to what we have now, there are longer recovery times and more restrictions until they heal compared to others. So I've just went over that. Creative approaches. Well, there's a lot of new non-traditional pathways that can give us reduced recovery time, smaller incisions. Benefits. Excuse me, alternatives. There's a direct anterior approach that can go really through the abdomen to get down to the lumbar spine. We move the abdominal contents out of the way. Spinal surgeon can do that approach, but generally we use an approach surgeon. There's also lateral approaches, and that's going in from the side, and that can either be done with the patient laying on their side or laying prone. And then we can do approaches that are a lateral approach with them prone, where we're going maybe a far lateral, including minimally invasive T-lifts or some new procedures like an OptiLift. So an anterior lumbar unibody fusion, again, usually using an approach surgeon. They go in from the front. I'm just getting over a cold. And get the abdominal contents out of the way. Usually there's the vessels that run on the anterior part of the spine. They've got to mobilize those and get them out of the way. Once we do that, there's usually a nice, safe approach pathway to get to the spine. And in doing so, we can get very good access to the disc spaces, can do a wide decompression, and that allows us to put in a big graft that's got a big footprint, a lot of coverage of the bone, and allows us to put in a lot of bone graft. And it's a very effective procedure to obtain fusion. Doing so, also sometimes depending on the problem, the pathology, we can do instrumentation from the front only and not have to go from the back also. There's also, we talked about the lateral approach, and there's several different companies that have instrumentation for that. That's when they're laying on their side. And from there, we can make a splitting approach of the muscle through the side, take the abdominal contents, move them anteriorly, and that allows us to get down to the muscles that's on the side of the spine. And those would be these muscles here, and that's the psoas muscle. Put a retractor through that just by splitting it, clean out the disc space from the side, put in also a fairly large disc space with bone graft, and also very effective. And sometimes in this approach, we can put in a plate from the front, and depending on the pathology, again, we may or may not have to go from the back. There's also minimally invasive T-lift, which is where we go for just off midline of the spine, and there, instead of ripping the muscle off the bone, we can split the muscle fibers, and then we can do a bony decompression and get access and put grafts in that way. Or we can do this alternative anterior approach, which you do with them laying face down, go extreme far lateral, and we can put in a portal into the disc space, into the anterior part of the disc space through a tiny incision. It's half a centimeter incision. And through that, it doesn't sound like we could do a whole lot, but we can clean out the entire disc space with special instrumentation and put in a very large device that expands and can cover the entire end plate and get very good distraction of that. And then in addition to that, you would do this minimally invasive screws splitting. This was a big advancement in the approaches. And just on a personal note, my wife had this done. We went to a colleague I know out of town, because not really many people do this. Had it that morning. Of course, we're in a hotel. Got home that afternoon, went to the pool, hung out, went to dinner that night. Never took any pain medicines at all. And very active. Now, others have had this done. Jennifer didn't mind me saying her name, and the outcome is variable. I don't know if you know my wife, she's very hard-headed. stoic. No, I'm the hard-headed one, but she's very stoic. So not everybody's going to be able to get out and do that, but it certainly is a big improvement. So navigation technology, there is new devices, advancements we can use, such as direct navigation, where we're using a particular eye that monitors what we're doing with our instruments, or robotics to help access the spine and put in instrumentation. Doing this allows us for smaller incisions, more minimally invasive, and usually a quicker recovery time. Different companies put out robots and visualization tracking devices. With the robot, you usually have to pre-plan the procedure. So we're getting a CT scan beforehand, putting that into the computer on the robot, registering it with fluoroscopic views, intraoperative, and with the patient. And then we just deploy the robot and it finds the pedicle. We put in screws that way. And then we sit down and drink coffee, and it's not quite like that. And then there's navigation, and in this, there are several companies out. Most of them, you don't have to get the CT scan beforehand, and we can do fluoroscopic views in surgery, get a picture of the spine, and then we register that to the instruments we're using and to the spine, and we're watching everything on a TV screen, and therefore we're getting good access, and it reduces fluoro time for us, but it's more accurate because we can watch it in multiple planes instead of just one fluoro plane while we put it in. Neuromonitoring, this is another thing that we use to improve outcome, improve safety. And it's been around a long time, but there's a lot more drive toward using it as data comes out showing that it is advantageous in improving our outcomes. So what is that? That's a service provided usually by a neurophysiologist who runs instrumentation that monitors the nervous system while we're doing surgery. During this, it gives us a real-time feedback during the surgery. And we can follow the sensory nerves, the motor nerves. And because of that, if there's changes, we can make modifications during the surgery to help alleviate any risk of problems after surgery. So just to give examples of where we would use this, if we're doing a fusion in the front of the neck, the anterior cervical fusion, well, the problems we may do that for include arm pain, numbness, tingling, weakness, or cervical stenosis where there's pressure on the spinal cord. And it's important to not put pressure on the spinal cord, well, any time, but during surgery also, and the patient's asleep, so they can't tell us if there's a problem. Positioning the head makes a difference because different positions can put increased pressure on the spinal cord. Well, when we're doing this, the patient's asleep, but we're monitoring the nerves, and if we put them in a position which changes the function of the spinal cord, we're going to get feedback on that, and we can take procedures to change that and alleviate that problem. Also, when we're doing the surgery of the neck, a lot of times we have to pull the shoulders down to see it, especially these no neck people who head is sitting on their shoulders, and we got to get exposure. But when we do that, we're putting pressure on the brachial plexus, and those are the nerves right here in the shoulder region after they leave the neck before it goes down the arm. So when we're putting the traction on during the surgery, you can end up having changes of the nerve function within the brachial plexus. And if we see that, we can take, again, action to change that and just relieve the pressure off the shoulders, which helps the brachial plexus. And all these things we've seen. Also, the access, we're going in from the front and moving over the structures, including the trachea, the breathing tube, which has the vocal cords in them, the voice box, and there's a nerve that goes there. So when we're putting pressure on it to get access, you can end up with dysfunction of the vocal cords. And that can lead to temporary or permanent paralysis of the vocal cord, which can affect the voice. Most of the time, if it does occur, it's temporary, but can be permanent. But when we're doing this, we actually monitor that also. And if we see changes, we can release the pressure off the retractor and modify it and alleviate that problem. So also we use it for posterior approaches. We're putting in the hardware, putting the screws, especially in a more complex case. And we've got a patient that's got pretty tough anatomy. They're very osteoporotic, scoliotic, big osteophytes. It's more difficult to see your anatomy. And using this, you have some feedback whether or not you have breached any of the bony structures, you're close to the nerves, and helps us monitor that to come out with a better, safer outcome. Biologics. These have been advancements that are continuously improving over the course of time. And these are useful because when we're using these, we can a lot of times decrease the amount of bone we have to take from the patient to use to obtain the fusion and get a better outcome. The gold standards, of course, is using the patient's own bone, either local bone from the place of surgery or taking it from someplace distant, like the hip bone, the pelvic bone. A lot of times people don't have a lot of bone. They've already had it harvested, or their bone is osteoporotic. It's just not good. So these have been a big advancement. So most of these, of course, are lab created. There's materials that are designed to improve the healing process, whether or not they're stimulating the bone cells to work or they're causing bone cells to migrate into the site. They're improving vascularity, different things to help achieve that. So, we say this complements the hardware because really the goal of the surgery is to get things to fuse, and you put your bone graft in, that's great. You put your hardware in, studies show that helps the fusion. But if you're don't have a good platform within there to get the bone to heal, then you're not doing anything long-term. All these fusion materials, biologics can be put inside the grafts we put in, put around it, put out into the bony structures around the spine. Different examples, there's putties we use that have different products in them. Infuse, which is common, everybody's probably heard of that, bone morphogenic protein. Allograft, which includes these generated bone fibers. So putty materials can include stem cells, chemicals that are normally in the body, which help stimulate bone growth. I-Factor is a new product that's out that is very effective. Studies show, and it's actually a derivative of a protein, which is in the bone healing cascade, which is effective, very effective. Bone morphogenic protein, the most common, of course, is Infuse. This is a normal chemical within the body that is within the bone healing cascade. Very, very effective in causing ingrowth of new vascularity, stimulation of the bone cells to proliferate. And this is a liquid we put into a collagen sponge, and then you use that. Very effective and very well studied for an anterior approach where you're going in from the front and putting the cage in from the front, equivalent to iliac crest bone graft. Again, these bone fibers really are cadaver bone that's been processed in a way that it comes out in fiber, so it increases the surface area for the bone to grow in, and it's very effective. You can just use cancellous chunks also, but it's kind of a different morphology. This can be placed in implants, can be placed in around the implants, kind of the same concept, fill bone defects. And then newly engineered devices also help with good outcomes, alternatives. We can have alternatives to traditional hardware, such as plate and screws. We can use this in combination with a decompression. There's options of metal-free stabilization, instrumentation, and all these can lead to quicker recovery, long-term better outcomes, especially, let's say, without the metal-free, because you don't have the problem with the instrumentation down the road later, loosening that may have to require removal, or adjacent level issues. You may not have to remove hardware to address it. So this Coflex, Cofix, these have been around a long time. really got a bad name because of just overutilization and inappropriate application of it. People using it on the wrong patient for the wrong problem. But it's very effective for the right patient, the right problem. You just have to be selective. This Coflex really is a device that's kind of a hybrid between a fixation stabilization and a device that just helps us with a distraction, but allows some motion. Cofix is similar, and it just allows fusion and stabilization of the spine within this spinous process, which is in the back of the spine, just an less invasive approach in a lot of ways, and doing compared to the open, not necessarily to the minimally invasive lateral muscle splitting technique. Also, there's new products out that allow stabilization of the posterior elements of the spine, and this is metal free. So it's really like a cable that goes around and through the bone to help compress it and stabilize it, which provides a lot of stability. Good option for some patients who absolutely don't want hardware. And this is also one of the things that helps out with the lack of pedal screws. And if loosening those kind of things or adjacent level disease, it can be an issue in the future. So it's not just us, it's not just surgery that makes a difference, and it's not just the surgery itself. It's everything together that leads to better outcomes, and that's the preoperative phase, intraoperative, and postoperative phase. And this is a teamwork. This is the patient, this is us, this is everybody involved. Insurance companies, employers make a difference. We really have to create this environment that's inclusive. The patient feels like they're involved. They know that we have their best interests in mind, and it's nice to know when the companies and the insurers have their best interest in mind. That includes building rapport with the patient, from everybody involved, and things that I know have affected it, just untimely approvals. You start dragging things out, then you create an adversarial relationship with the patient, and that makes it so much harder to get a good outcome, which affects everybody. It's tougher on us. The patient doesn't want to get better a lot of times because they have a grievance against the company or the employer, and it costs more for everybody. So, all those things work together to get there. And, this talks best outcomes. I hope this was the best outcome, but we'll see. I appreciate it. Anybody got any questions?
Common factors that lead to better outcomes, for the patient, pre-op health or post-op care, anything that we
Yeah, I didn't really go into all those as part of this, but sure, you've got to maximize outcome with the patient. Things that can affect it are, if they're diabetic, is their blood sugar under control? Do they have appropriate vitamin D levels? Are they smokers? What is their underlying motive? Are they being honest with you about their true problem? How much secondary gain issues do they have? A lot of these things go into it pre-op. So, all right, I appreciate it. Okay.
Dr. Smith. Thank you, Dr. Smith.
Thank you.
We're running a little ahead. Are you ready, Dr. Ogden? I don't know if she's here yet. Y'all take a pause.